delay, I'm going to allow Minister to lead. Over to you, Minister.
Well, thank you very much, Foster, and thanks also to Dr. Crisp, and good afternoon, ladies and gentlemen. Today is indeed a very historic day that just about an hour ago or so, the National Assembly passed the National Health Insurance Bill. As we know, in terms of process, this will now be submitted to the National Council of Provinces so that they can get concurrence of all the 9 provinces. But this in itself is a major milestone. We've been on this path over a long period, almost 12 to 14 years, starting with the policy development under the Green Paper, followed by the White Paper, and ultimately the bill itself. And as you might remember that this bill was also delayed by the advent of the pandemic, because soon after it was submitted to Parliament, to the National Assembly, then the pandemic descended on us, so causing a lot of delay. So we're very grateful to all the members of the Portfolio Committee, starting with the leadership of my current colleague, Deputy Minister, Dr. Lomo, who was the chair of the committee, and subsequently taken over by Dr. Jacobs and all the team in that committee. We believe that this lays the foundation for a major reform which is needed in our country. As we said in the House, it's a major milestone in the sense that since the advent of democratic South Africa in the health sector, we've focused on improving access from the time of President Mandela, policy decisions taken in terms of free access to health services for pregnant women and children under the age of 6, and subsequently a policy to open up primary health care services free of charge to all users, and overall an expansion of the public health capacity in terms of infrastructure, in terms of human resources, in terms of all other equipment and capacities. But one of the downsides over this period has also been, driven by an approach of our, overall economic policy of a mixed economy. Together with that, then making it possible for also quite a major growth of the private health industry, both at the level of financing in terms of your health insurance products, but also, and with the growth of the middle class, as the economy was growing, so a number of people who were excluded from the economy starting to have access to reasonable income, also with the growth of the public service across from the 3 spheres of government, local government, provincial and national, and also various growth of other various entities. So a significant growth in the people who have income, and with that, opening up opportunities for medical insurance, and then of course also allowing also a growth in the private health care provision itself. Some years back, before 1994, there would have been just a handful of private health providers, especially at the level of secondary and tertiary services at the hospital level. They would largely have been mainly GPs, dentists, and those kind of services. But what that over time has done has been to create a 2-tier system, which has developed its own complications in terms of the distribution of very scarce national resources, with a situation where, on the one hand, you have the public health sector continue to be the base, carrying the base load of looking after South Africans, and with significant investment, but not possibly as strong as it could have been. On the other hand, taking away some of the user fees and collection, and with the growth of the providers on the private side, becoming also quite a complicated situation where the cost of those services have also just been spiraling. And so having reached that kind of stage now, it has been the reason why the debate about reform of the system has been an acceptance by various role players that this direction of a two-tier system with one increasingly carrying a bigger load of your general population, but the other one consuming huge amount of resources, which, if there was a kind of sharing of those resources, could also contribute towards the vast majority of the population. That's why this debate about what kind of reform is required, and that's why we are saying that today it's indeed a very historic day in the sense that the basic legal framework for reforming of the system is now being laid. Of course, the journey is still halfway because it must still go through the National Council of Provinces, but it lays the foundation for an approach which can result in a situation where both the contribution from general fiscus collections from the revenue service, but also those contributions which many of us who have income are making into private into private insurance products, generally called medical schemes, can then be able to find a formula through which all those extra contributions can be pulled, and we can be able to use that muscle to increase the capacity. The public health system will remain, the mainstay in terms of carrying the provision of the services to the vast majority of the population, but with a fund established which can also be able to access services from the private providers at a more cost-effective, cost, will be able to expand both access. We know very well that while your public health system is overburdened with demands, many of your private hospitals, some of them are functioning at less than 50% at any given time in terms of capacity. I mentioned the other day when we were at the Presidential Health Summit that I was talking to an old colleague of mine who's a doctor who's gone into the industry of private health, who's got 1 or 2 hospitals. And we were just discussing because I happened to be in Durban and I was at the Pres Mandela Hospital. And we're looking at the kind of pressure of services at that hospital and talking to the management there. Amongst other things, we're talking about maternity services. And I was asking, what is the number of deliveries happening at the Pres Mandela Hospital? And they indicated that in a month, they deliver between 1,000 and up to sometime 1,500 babies. And when I was talking to this colleague, obviously, the private hospitals are not as huge as, but in the same city. And he was saying to me that in this hospital, if he delivers 60 babies in a month, that's a big, and that, especially after COVID, that is, he hardly ever even sees that. They're usually between 30 to 40 deliveries, almost 1 delivery a day in the entire hospital. So that's the kind of spare capacity which exists. And of course, in order to what it means then, therefore, is that they are suboptimally utilized, but to maintain them and sustain them and still make a profit, they have to find ways. And that's why you will find, again, just as an example, and he himself confirmed what, in the same city, I was meeting some pediatricians, and they were complaining to me to say, you need to do something. In the private hospitals, you have a cesarean section of up to 80% of all deliveries being cesarean section. And this colleague of mine also confirmed that in his own private hospital, they do up to 70% of cesarean sections. So there are a number of factors which therefore makes it much more costly. So we believe that the passing of this bill today, as it is still going to go through the Council of Provinces, start to lay the foundation through which, if finally it can be signed into law, it will create that framework and foundation for us to be able to reform the system so that increasingly we can go into a direction which is different from where we are going now, where you have an over-concentration of almost over 51% of the resources utilized by South Africans for health services being in the private sector for only 16% of the population. And if we could find a different rationalization of those resources. And I must also hasten to say, what we're envisaging is that the kind of expenses which individuals who are on medical insurance have to part with, once the process can be really functional, and where we can share and rationalize those resources, people who are having income will not have to spend anything close to, hopefully, even a half of what generally those of us who have income currently are spending on medical care. We believe that, of course, this is the early days, even once the full act has been passed and signed into law, its proclamation of various components of it to function. But we believe that there is already elements within other reforms and other experiences, including COVID itself, that there are a lot of experiences. Just to give you an example, just the issue of the health information systems. Currently, I was, again, when we were going to the health summit, I asked the DG and the DDGs, we're looking for just basic data from the private sector, including maternity services, children's services. And it became clear that we don't even have the clinical data. We don't have a system through which we only have public health services data. When it comes to what happens in the private hospitals, the very important clinical data which we need also for overall national planning is not there. But during the high levels of rollout of the COVID vaccination, we developed within the department the electronic vaccination data system, which was led by Dr. Chris Pierre, with his team in the departmental health information systems. And that system proved to be quite reliable. At the end, we had one system. We're able, whether a person vaccinated in the public or in the private sector, on a daily basis, we're able to know where we are, and this data is still available for us. So there are a number of areas in which a lot of groundwork has already been done, but we're also conscious of the fact that there's a lot more which will need to be done. We know that some of those who opposed, including in the debate today, they argue that rather than interfere with the private health, we must just focus on the public health. And we disagree because at the end of the day, we are one country. And we believe that while there's room for private investment and input into various aspects of health, but the final access to health services when people need health services it can't be correct to be treated like any market commodity where you must buy. There are elements within the health value chain, producing of medicines and equipment and diagnostics and so on. There are a number of areas where there is huge opportunities, but we believe that at the end, when somebody is ill and needs to be attended to, and even because it's also health doesn't start when you are ill, but in public health, in prevention, in promotion of health, good health, all those things need all of us to contribute towards. So in conclusion, I just want to say that we do understand why there will be some genuine South Africans who will be skeptical, and we understand that those who oppose interventions such as the NHI take advantage of some of those legitimate concerns in terms of the capacity of the state, in terms of implementing a number of projects, running a number of institutions. It's not something we can wish away. We must make sure that those things get fixed, including in the current provision of health services. It's not only the pressure, but it's also in a number of clear examples where there's been mismanagement. In some areas, in the extreme, also some elements of corruption have also been unearthed, and those must be dealt with. But we also say that within, if you look at the base load, which is the public health system again, there's also good examples. There are a number of examples of well-functioning institutions, despite the pressure under which they function, but who are managing, to the best of their ability. And we do from time to time get messages of a number of people who are very complimentary about some of the services which they receive in quite highly burdened health facilities. So we want to assure South Africans that we are conscious of all this, and we're paying very deep attention to them to make sure that the managerial and leadership risks must be addressed, and that's why within the policy itself we have said that the NHI implementation is not going to be an event. Today's passing of the bill is an event. It's in the Assembly, it's passed, but actual implementation is going to be a process. And we have said over and over again that it will be in stages, with a major focus on primary healthcare and building up into broadening a number of other services to cover all South Africans. So we will definitely handle this reform process with care. Thank you very much, Foster.
Thank you, Minister, for clarifying for the process as far as the NHI bill is concerned. So I believe we've got other journalists who are following us through the social media. So colleagues will be able to read out the questions, but I'm going to start with those who are in-house. So let's see, Tama. Yeah. I know we communicate from time to time, and also with Minister Dr. Chris. Just mention your name and the media house you come from. Yeah.
Good evening, Minister. Tamal Khan, Business Day. In the 3 weeks since the bill was adopted by Parliament's Portfolio Committee on Health, there's been a barrage of criticism and concern expressed by big business, industry associations for medical schemes, healthcare practitioners. It's been quite forceful, and they've been unusually vocal. To what extent is this perhaps giving you pause for thought or identifying areas where you may be open to legal challenge? And with that in mind, with the ANC, do you think there is scope when the bill makes its passage through the NCOP to perhaps fix some of the weaknesses that are being identified by these kinds of stakeholders?
Thanks. It's Carol Payton from News 24. Minister, since you introduced the bill at the beginning and since it got in the form that it passed, there wasn't much change made to the bill. It kind of changed in pretty much, came through pretty much as it was in the beginning. Does it worry you that there's been a huge amount of criticism of the bill? None of the sort of political parties of any substance backed the bill. None of them supported it. And as Tamar is saying, the private healthcare industry has been very vocal about opposing it. Does it concern you that you stand alone as the ANC with this policy, which, as you say yourself, is really a high risk policy in the sense that the public doesn't trust you're going to be able to do it, and you haven't got a good record in terms of what you've been able to deliver. For most of it, I do take your point that yes, you do have good public health care as well as bad. And then secondly, I mean, what's What do you think, Paul? You spoke about, you know, how the private sector, how the market allowed this private sector health industry to burgeon over this time, and there were more people with wealth, and kind of everyone was making lots of money, etc., etc. What do you think will happen to that health sector once you have an NHI? Do you expect that you'll continue to have a thriving health sector as a sector of the economy, or do you think that will kind of wither away as people who, you know, decide to rather go and make money elsewhere? Thanks.
Thank you. Any more questions from the floor? Pule, do we have questions online? Yeah, I received a few questions from journalists who said that.
Can we take this first?
This one first. Okay, thank you.
Then you can take it. Well, thank you very much. I think the questions are very, almost like in the same direction. So the issue of a number of organizations who have raised unhappiness about the bill and the fact that not much has changed. I think firstly, I think the challenge in my understanding, because we have had to be called now and then by the committee to come and respond. After the public hearings, we had to come and respond to a number of issues. Now, essentially, one would say that some of the areas there, I mean, there are some areas which you would say soft areas, maybe, where you would say, okay, maybe something different could be said. Let me take, for example, I think even in the House today, there's one or two people who raised the issue about the power of the minister in appointing this committee, the CEO, and so on. And there were proposals, for instance, that why doesn't Parliament? And there was an amendment, as far as I know. The original simply said that the minister will appoint the board after a public process of nominations, and then also the CEO. But then there was a pressure from some of the parties which were saying, why not give this to Parliament? That you should amend that to say the board and the CEO will be appointed by Parliament. But what you know, when we looked at it, we looked at the other risk in terms of that. I mean, just look at the SABC, and we said, do you want, you know, you could take, I mean, in a way, maybe there's a particular history of the Public Broadcasters Board being appointed. But, I mean, if the SABC doesn't have a board, like over the last, 5-6 months, ordinary South African doesn't really feel it. You know, that there's a lack of governance at the SABC. As long as they tune on the radio and the music plays, the news are there. It's those of us who are concerned about actual, you know, high-level policies and so on, concerned, you know, is there proper governance there? But the question had to be to say, if a major thing like the kind of institution you want to create, which would manage, you know, the life, the health life of people, making sure that that institution functions, it can purchase services, it can service the providers and so on. If you go a direction which is kind of good gesture publicly, but which then puts this into the space where there can be stalemates in the Parliament. I mean, you can imagine, God forbid, we don't end up in the national scope of sphere of government like Johannesburg municipality or Tshwane. And then you say, a coalition, like if you had a Johannesburg Council to appoint a board, let's say, similar governance system, and you throw it into the Council of Johannesburg, I mean, you're going to get paralyzed. Or it's just scary to say, maybe, you know, even at national, we're not yet, there's still dominant parties, but you still get stalemates on certain issues in terms of, because politics then come in. People start to look at, oh, so-and-so is nominated, where does he or she lie politically, and so on. But that's why then the amendment which was then proposed and approved by the committee was to say the minister must appoint after approval by cabinet, that it mustn't be a single person. Of course, others will argue that, well, cabinet is still the same, whichever party is in power, and so on. But the argument would be, if in our system, if a party which is in power, in government, has the responsibility to provide the services, so it must take responsibility, including the people who it deploys. So for that reason, those are some of the softer issues. But there are other more harder issues which also some of the parties, you know, would come with. For instance, there are parties which are dead against any national central system of operation of any, and who philosophically are in the political philosophy of federalism. And you hear them when they speak now and then. They will not speak generally about the nation, but they will isolate particular, especially if they control a particular area of sphere. That's what they will champion. So that's just philosophically, political and philosophically, the idea of building a national health system, but devolving it too much also on a federalistic approach, is also just will defeat the purpose. And then, of course, there is an issue which has been raised. A number of not political parties, but interested groups, especially in business, about the future of the private medical schemes. Now, basically, from a fundamental policy perspective, you either do have a national system of, you know, financing and contributions, a social solidarity, where, as we said in the House, the rich subsidize the poor, the young subsidize the old, the healthy subsidize the sick, and you create that pool of sharing. That's how it works in countries which have, remember, we're not the first, this is not the virgin path. They might differ in details, but these are systems. I know that in the House, some of the opposition members said the NHS of the UK is on its knees. As far as I was myself and Dr. Crisp were in the UK in was it November. With the president, and we had a number of interactions. We signed agreements with the UK. They are under particular pressures, but the system is functional. And I can tell you now that that's why I said in the House, notwithstanding its challenges, it doesn't matter whether you have a Tory government or a Labour government, you know, all of them would not speak of dismantling the National Health Service, but rather how to improve it, how to strengthen it. So some of those, where people want multi-entry or multi-systems of insurance, it will defeat. If we go that route, I'm not closing to say the NCOP can entertain whatever, but in our view, from a policy perspective, you make a choice. It's either you're going to create a social solidarity or you keep what you have, where it's either you have an income and then you contribute. And even when you do have an income, even when you contribute, when your benefits are exhausted, you are told your benefits are exhausted. We can't keep you here. I mean, not long ago, I was talking to a professor of cardiology at Steve Biko, and he was telling me I've got a number of patients from private hospitals. They had their benefits exhausted. They were done investigations. Sometimes those investigations in the private sector can cost up to R5 million. And then at the end, when they arrive at the diagnosis to say you need a bypass, you need a certain repair of your heart, their funds are exhausted. And then they refer them to me. So I admit them here to come and do the procedure. So we are saying, therefore, that it's either you keep the one which is, survival of the fittest or the solidarity. And you can't have both. So the issue here is, but I think the crafters of the bill were also very conscious of the fact that this can't happen just at the, the click of a finger or whatever. That's why it says in the bill that progressively, there will be coverage progressively, and at any given time, when the NHI is running, when it can cover certain services, private funders will be excluded from covering the things which the NHI is already covering. If it covers maternity services, private funders can cover other things, cataracts, whatever, and other things which the NHI at that stage is not covering. And if it improves and start to cover cataracts, then those cataracts, the extraction of cataracts will never be eligible for private coverage. And only when it can reach a stage where there is a 99% of full coverage of all the services from young to old, then at that stage will then private cover not be an option, and only things which out of the 99, the 1% at that stage which is not covered will then be available. So Tamara, in terms of whether when it goes to the NCOP, some of the things, you see, if it's things which makes it which makes the bill then to actually become irrelevant, it will be futile to then simply just say, because there's an outcry. If you were to, we know that these are powerful people. As you have said, I've said myself that over time, and it's a fact. It's a fact. When the democracy started, when I finished my medical school, I won't mention when, it's too far away, too long ago. There were very few private, even in where I studied in Durban, very few, and even in 1994, very few. But because of the democracy and the freedom for business, this all grew. So it does impact. It does instill some fear. But I can tell you, in the same way as, for instance, I'll give you another example. The huge battle was in '96 or somewhere around there when our first Minister of Health, Dr. Nkosazana Zuma, introduced the tobacco bill. Huge outcry. Things are going to collapse. Sports is going to collapse. But what happened? The moment it became law and it was enforced, business found other ways. There's the investment in sports, cell phone industry grew. Now we don't even remember that there was some sports activities which were sponsored by, I remember when I grew up, those who follow football, there used to be a Benson and Hedges cup long ago. This was a tobacco, tobacco. There were a number of cups which were sponsored by tobacco companies, and other industries then found. So I believe that we do understand the concerns, but some of those we will navigate carefully. We will listen, even as that opportunity comes. Maybe from Ms. Carol Payton about the fact that we almost on our own for different reasons. If you listen into the House, the two bigger parties, you've got the DA on the one side saying we're going to destroy business, and the doctors are going to leave because of this and that. And I mentioned in my speech that in 1948, when the NHS was introduced in Great Britain, huge outcry from doctors. The doctors never approved it. They fought. They promised hell was going to break loose. And the government, they were very focused. They went on Today, if you speak to, I went to, me and him, amongst the groups we spent some time with was the GPs. It's an organization of GPs in the UK. And they are the biggest defenders now of the National Health Service. So some of this we do understand, any change is painful. We must handle it with care, but at the same time, you don't close your ears, you listen, you look at experiences, but you navigate carefully, but at the same time. So we look, just going back to the National Assembly, the DA is about, the criticism is about destroying private business, scaring investment, and so on and so on. The EFF on the other side says, you are just pondering to business. We are going to oppose you because you don't want to say you're going to rely on the public health system, build the public health system. You say you're also going to buy services from the private sector. So you are just a tool of Bill Gates. You are just a tool of business and so on. So in a way, one would say, I don't know, some people say, if you are hit from the left and hit from the right, and it means you are on the right path. Because neither the left nor the right believes you're correct. You must be doing something right, because they're both extremes, in a way, expect you to be with them, and you know that there's no room for extremism in this regard. In terms of the risks, also in terms of track record, we do accept that it's a challenge. We accept the challenge even about COVID. Even about COVID, there are some bad apples. Overall, in terms of the performance of the public health sector, looking after patients, rolling out vaccination, the public health workforce carried the bulk of looking after people with COVID. And many South Africans survived because of the fact that even when private hospitals were full, they could go. Of course, there were times at the height when you couldn't have a bed, not only an oxygen and so on, both in the public and private. But when we started with the vaccination, it was it can be done. Carried largely by public health, it won't happen. And there it is. And at the end, we struggled to access, not because of our own, maybe some say we could have started early, but when we had the vaccines, we were able to roll them out. Not a single kind of issue of mismanagement. What we have is a situation where a number of vaccines have not been taken up, and we are going to destroy some of them because of a poor uptake, especially because of the delay in accessing them. But I'm not aware of any mention that vaccines were stolen, mismanaged. Huge. We gave up to 40 million doses.
39 million this week.
Yeah, just under 39 million doses of vaccines, administered, and not a single. But because it's a good story, it doesn't get the front pages. But over and above that, also just in terms of the reality be told, of course, the bad apples do spoil everything, your ESCOMs, corruption, and so on. But there are also public institutions which are working. You've got the South African Revenue Service. There was an attempt for it to be captured. It didn't succeed. You've got your government employee pension fund. Government employees don't have anxiety when they retire that their money may be lost in the government employee pension. They get their money. And there are a number of others, your Industrial Development Corporation, there are a number of institutions, even within the health sector. Dr. Crisp was very instrumental in establishing the National Health Laboratory Service. It's got its own weaknesses, but it's functioning. It carries all public health facilities are run through the National Health Laboratory Service. They get their results and so on. You can look at the SAPRA. He was also involved in the establishment of SAPRA. It had teething problems. It's now very stable. It's processing all the applications and so on. The South African Medical Research Council is churning out good quality research, respected all over the world. The scientists from the SMRC are called to international conferences. This is a public entity which also reports to us. So I want to say that we are not oblivious. We would have loved that at least one of the two main political parties, we are very comforted, even if they may be small, a number of about 4 or 5 small political parties, even PAC, AIC, GOOD, they may be small, but they are also a voice of the people. the fact that the two bigger parties, of course, at some stage in the committee, the IFP was supporting. And then I asked the chief whip of the IFP, he said they made a decision last week because they are concerned about certain issues which we must discuss. I said, no, fine. We still have time, we must discuss, because for the last 2 years, IFP has been supporting. And then he says, no, it was a decision about 2 weeks or a week ago where they taken this decision. He says, no, let's talk. We think it's something which can be addressed. So the issue of what is the future of private health, I believe that some aspect of it, both at the funding level, as we said in the bill itself says on the funding side, on the insurance side, that it will be incremental in terms of coverage, and that which is not covered, private sector can cover. But of course, a business wants everything. So to grow, you want now. I mean, the scramble which is there now, it's that there must be a low-cost medical schemes, and everybody's scrambling to develop a low-cost which can't even pay for a GP, or can pay one visit in a year to a GP. I mean, the people who really need healthcare, if you say you've got medical cover, it allows you one GP visit in a year. I mean, if you are over 50, most likely you need blood pressure tablets, you need this and that, and so on. So it's going to be just for the young people who probably over a year will not even visit the doctor once. So those are the kind of things which can't really be sustained. On the service side, of course, the high level of profit which is possible in South Africa, and I mean, if you look in the continent, if you look even beyond the continent, the kind of profits which are possible in South Africa, you hardly find them, except maybe in oil-rich countries. But even there's a lot of control. Maybe Saudi Arabia, UAE, where they've got a lot of oil. But overall, some of the things which are because of the inequity of our system, you can't really, say that even if we are not to do anything, they're going to collapse on their own because of the fact that as more people can't afford and they fall off. So I mean, one is of the view that some element even in the service side of some ethical, if there is ethical business, I believe there is possibility of ethical business. That element of those can still survive concurrently with the public service. So I know I've been long, but I think that's really my view and the philosophy behind the national health insurance.
Maybe before we take the second round, we can just check whether there is any input.
No.
This goes through just a few questions, unless there are follow-up questions in the House. Just 3 questions. The first question says, how long will it take to get to the NCOP? How long will it take for the bill to get to NCOP? Number 2 says, secondly, various stakeholders within the opposing parties have indicated that they will challenge the bill in court. What's your comment on this, and how will this affect the legislative process? Last question, Minister, please give a detailed update on where we are with regards to implementing the recommendations of the health market inquiry. Will this not make more sense to start there instead of having the parallel process? Or is it not necessary to start implementing the recommendations of the health market instead of start going to the bill? I think these are the last questions.
Let Dr. Chris take the last one, and then I'll come back on the others.
Oops. Okay, thanks very much. Thanks, Minister, and thanks for the questions. So the health market inquiry was concluded, and the results were made public shortly before COVID happened, and we were in the process of examining them and comparing them with what it was in the A bill, so the original bill, to see where the concurrence lay with the national health insurance that was laid out in the bill. There are a number of recommendations which are good and positive, but there are some of them which couldn't be, even now, can't be implemented. For instance, they recommend creating a Schedule 3A public entity. You can't create a Schedule 3A public entity without an act. So that is, and the entity they are referring to was to have a supply-side regulator. Well, that's exactly the role of the NHI, is to be the supply-side regulator, but for the whole system, not just for the private sector. So it would be superfluous to have another Schedule 3A entity just to regulate the private sector while we're waiting to create the NHI. However, there are clauses within the National Health Act that we are using and within the Medical Schemes Act where we are examining at the moment who issues licenses, why they're issued, where they are. And I think you're all well aware that sections 36 to 40 are still in court. We are waiting for the outcome of the rescission hearing, which took place a couple of weeks ago, where that deals with the certificate of need. Now, all of those are interrelated matters. The outcomes, questions that were raised and recommendations that were made, that is a major function of the NHI, is to measure and invest in strategic purchasing to get better outcomes. So why we would want to create a separate outcomes measurement for the private sector when we are already, that is part of what we are doing in the NHI. So it is part of what we are doing and why we need this bill so that we can get better outcomes measurements. So there are also other elements of the good recommendations in the Health Market Inquiry that were impeded by previous decisions of the Competition Commission. We have who are the fathers of the HMI report anyway, and they have been in engagement with us talking about how certain the decision around the reference pricing was amended many years ago, and why that has not been constructive but rather destructive in the private sector space, and working with us to say the recommendation of a single common compulsory option for all medical schemes should be implemented. Well, we agree, and we would like to see the revision of the prescribed minimum benefits harmonized with the primary healthcare package and become that single compulsory product, or if you like, or option, because that's exactly where the NHI is going, and it will dovetail with the intentions of the contracting units for primary healthcare in the NHI bill. So where there's harmony and we're all moving in the same direction, we are definitely already doing things. Perhaps a last example is that we would like to see greater autonomy of management of all public sector hospitals. That's a long road, and there are reasons why it has evolved into a very centralized system within the provinces. But in the NHI bill, it starts with the central hospitals being nationalized as national functions, but with maximum managerial autonomy that the public service allows. It will put them on the same kind of footing of a manager in a private hospital being responsible as the CEO for that private hospital. But we'll have to go through the steps because that's governed by a different piece of legislation, the Public Service Act, and we will need to work with the Department of Public Service and Administration in order to get that permission from the President. So, Minister, I could give other examples, but I think that's sufficient.
Okay. Very briefly, these are very brief areas. How long to the NCOP? My experience and understanding as the House is rising today, and you would have, I mean, the Speaker or the Chair said the second reading is now done in the National Assembly. The Speaker will now refer this to the National Council of Provinces. That's with immediate effect. So when the House rises, that bill now becomes a subject of discussion by the Council of Provinces. What is expected of Council of Provinces is to consult each province. The Council of Provinces works as it is called, because everybody there represents a province. So there will be consultation of all 9 provinces in their legislatures, and people will make presentations at the legislature. And the legislatures of provinces will then make a decision. Each of the 9 legislatures will make a decision, and then those decisions in support or not supporting will then come to the sitting of the National Council of Provinces. So they will have their own consultative process. The actual timelines is now is the purview of the chair and the deputy chair, the whips. They will decide on a program. They have a committee.
We just received the invitation.
The 20th. Okay. So they've already invited us to come and make a presentation, because once the House, as I say, the House rises today, is their property. So they've given us a date for next week already to come and present the bill to the committee of the NCOP, after which they will debate, and then they will take it out to the various provinces. The length, as I say, is not in our control. It's the members, led by the chair and the deputy and the whips of that committee. The court challenges, well, we live in a constitutional democracy. A number of people have either as businesses or individuals or groups have pointed out certain areas which they believe are unconstitutional. It won't be new for a bill or an act, once it's signed by the president, to be taken to court on either procedural or substantive. Others, I suspect from the report of the committee, at least from the National Assembly, on a procedural basis, it's likely to be very difficult, because I think the committee, from the report which you got, they tried to follow very strictly the procedures which are expected. So it might be on, as others have said, a constitutional basis, taking away powers of provinces, and others where they say, some allege that the bill takes away individuals' rights to choose this and that. So it's in the nature of South African, dispensation, political dispensation, that even on an individual basis, somebody who's unhappy, the courts are the highest arbiters. So we have to be ready once that materializes to make sure that on behalf of the vast majority of the people who have been waiting for some steps to start addressing equity, as a government, we will have to go and defend whoever, even if it's multiple parties, we'll have to be ready to go and defend at the highest level of the courts in the country. Thank you very much.
Thank you, Mr. and Dr. Chris. Any follow-up clarification, second question, Carol Trump? On that note,
I know this isn't strictly your domain, Minister, but one of the big questions, of course, is the financing. And for almost as long as I've been a mother, which is more than a decade, we've been asking questions about how this bill is going to be financed and what kind of model or mechanism you're going to use to fund it. Has there been any work done on that? Has Treasury done anything? Are you talking to them? Where's the money going to come from?
Well, remember, Treasury is part of this government. There is no Treasury of some other. There's one government. This bill has gone through Cabinet, has gone through Parliament, of which at various levels of discussion, the Treasury is part of that. Now, I can ask Dr. Crisp just to speak to the particulars, which we have often indicated that even talking to some of the experts who we do consult at the level of the World Health Organization, the approach which we have been cautioned is to say, don't go that route of, wanting to package things now. And he'll speak more, he's more of an expert than me. But I also know just from basic experience, and that's why I said it in the House. If you're going to say to me, for instance, in South Africa, we're used to fee for service. I think, my predecessor and colleague, Minister Mtsoaledi, always wanted to give this example. But if you ask how much does a circumcision cost, it depends who does it. If you do it in the GP's room, which is safe, even currently, I'm sure you won't pay more than 600 rand. But if you do it at one of the listed companies' hospitals, you'll pay 10,000 rand. Same thing. So which one do you take when you want to cost a circumcision? Do you take the GP room? Do you take the tertiary hospital listed on the stock exchange, which is going to charge you for, they open a packet of swabs, they use one swab, they charge you the whole of it. Everything. A needle, open a package, they charge you the whole box because they used one needle. So which one do you take? So I'm just giving you a practical, and that's why they always said to us, you must determine your approach. What services at what level? You see? Do you want to, I'll just give you an example. If you were to say, you've got 1 million women, you've got 1 million babies on average in South Africa a year. How do you cost a delivery? How do you cost it? If you're going to do that delivery at one of the listed hospitals again, 80%, as a pediatrician complained to me, you're going to get a cesarean section, 80%. If you have a primary health approach, you probably at the most get 20% of a cesarean section, if not 15%. The majority of those will be done by a midwife. I mean, I'll just give you a personal experience. I mean, somebody quite close to me in my own family, and they said, no, look, I'm going to deliver, there's a midwife just in the center of Pretoria. I'm not going to go to a hospital. And this is a first-time mother. And she went there. I was a bit anxious, and everything went pretty well. Big baby, over 3.5 kg, delivered by a midwife. And if she had gone to one of the listed, I would have had to pay maybe quite a few months of my salary, part with. So you get my point. So if this insistence that give us a price, we must determine, this is the approach. We say primary healthcare, we must create the package. We've got a team which Dr. Crisp is putting together all these building blocks, including the packages, the package of services. We must look at that. If we're going to do this, it's going to start at this level. You need to get this expertise, this and so on. Only when this and this happen, then you, for instance, just a delivery, But in terms of if you're going to go to what the scary thing which the opposition is telling you, they're telling you the cost of a top-level obstetrician and top-level anesthetist in the theater, because 85% of those in the private sector will be in theater, will be cesarean section. So if you're going to cost it by that, it's not affordable. But if you're going to know that 90% is going to be done by midwives, this is quite affordable. So which one do you take? But I'll leave Dr. Crisp to give a more expert. It's a little bit of a GP's view because that's where I ended up.
Thanks very much, Minister. So, we've been cautioned repeatedly by the World Health Organization economists that we have worked with over the years, and by countries who have already implemented not to go the route of trying to cost anything. And we have said that very clearly on the 12th of December last year, when we brought out those same economists to be part of the UHC Day, and I met, some of you were actually there, and so you're familiar and you saw the presentation. So they've told us, don't go that route, don't do it. What you do is you fix what's affordable, and you try and understand where you are wasting, and you get rid of the waste. So we are wasting in the public service by having 9 different provinces all deciding the same thing over and over and over again, buying equipment, redoing the tenders, redoing the IT systems, redoing everything. We waste. And we waste because we don't have digital systems in place, so we are not able to share all our lab results and X-ray results, and we duplicate them. In the private sector, I was just checked on the actual figure. It's gone down to 72 medical schemes now, active as of today. Those medical schemes also protect their data. They protect their private information. And that's why when the Honourable Minister said in the House that we don't actually know what's going on, and he repeated it here, we don't actually know the outcomes of what goes on in the private sector because they protect that for proprietary reasons. We need to know that kind of information. But what we do know is that the cost of administering the money by the administrators and by the funds before you give any healthcare is 15%, 1.5. You have to have thousands of brokers, you have to have all these medical scheme boards of trustees, actuaries, all trying to develop new packages all the time to outsmart one another. It might be good for their business to try and get ahead of the game, but it's really bad for the patient because that's waste. So if we can get rid of just that waste, if we can share and have one common patient record, which you've heard we've been developing for some time, and which is all carried on a health patient registration system with single numbers, the amount of waste you cut out of the system is huge. Then on top of that, the health market inquiry told us about exactly what the Minister's speaking about now. Huge caesarean section rates, huge grommets rates, tonsillectomies, like 4 or 5 times what you expect anywhere else in the world in private sector practice. If you can get rid of that and do that in a better, more efficient way, you again save money. So the point of the exercise is really not to see if you can do number counting and anticipate 10, 15 years' time, this is what we'll be spending. What you have to do is say, a country like this, it's reasonable to spend somewhere between 7 and 8% of GDP on healthcare. We are spending 8.5% at the moment. So let's say that's reasonably affordable as a nation. What can we get for 8.5% of GDP? Whether it grows fast or slow, what can we get? And then we go for using the numbers to push the prices down. That's exactly why you need one system. So when we purchase pharmaceuticals in the public sector, we get them for sometimes less than 1/10 of what they pay for them in the private sector. Imagine if we were all getting that kind of prices because of certainty in the market, large volumes, no problems for the providers, for the suppliers of those goods in trying to anticipate and have the logistics to distribute one dose rather than the large doses that go in these big systems. There are many, many examples of how we can tighten up and improve what we are doing. Basically, we are a very wasteful system at the moment. So I think we are comfortable. This is the route we're going. We do talk to Treasury. We bump heads from time to time as officials. That's healthy because it makes us think and be sure that what we're doing is right. Thank you.
I think you have said the mouthful. Then the rest we can still be able to interact beyond this media briefing. Let me take this opportunity to thank you for being patient when we're still trying to sort out some issues. And also thanks, Minister, for